Good afternoon, everybody. We are still waiting for several more folks to join, so please be patient with us. If you are a committee member, please put your name in the chat so we can make sure we get you down for the meeting minutes. If you are a committee member and you're on the phone, please unmute and let us know that you are here as well. Thank you. We should get started here in just a few more minutes.
This is Kim Danzy. I'm here for my first time.
Hi, Kim. Welcome.
Hi, everybody. I think we're almost ready to get started. Sharon, how are we on quorum?
We are good.
Oh, great.
Go ahead and get started, Jesse. We've got a quorum. Thank you.
Yeah, terrific. And Jesse Lydell, I just stole your background because it looked so soothing and nice. So if you're if you're still on the call, I took that from.
You're welcome.
It's the Jesse background. Hi, everybody. Happy 2022 and welcome to the January Medicaid Advisory Committee. Just as a reminder, we have made a determination to continue these meetings virtually for the safety of everybody, safety and sanity of everybody during this time. So these meetings will be held virtually until further notice. And we have a new member. So we have some membership updates all around to share. But first, let's start with welcoming Kimberly Dancy, who's the new HCBS and home health provider on the committee. So Kimberly, are you on the call? If so, we just want to welcome you. So feel free to unmute or unvideo yourself and say hello.
There we go. I'm here.
Yay!
So I'm really happy to be here. Thank you so much for allowing me to participate. I'm a vice president at Community Nursing Services, and So have worked in home care for a long time and looking forward to being a part.
Awesome. Thank you so much for being here. And Kimberly, what I generally do is I'll follow up with you after this well, we're going to actually talk today. Usually we don't, but we'll talk today about just what the MAC is about. But I'll follow up with you too, just offline about any conversations or any questions you might have about the committee and what we're about too. So you'll see an email from me in the next week or so. So great.
Thank you,
Yeah.
Jesse.
Welcome so much so great to have you. So yes, we have a new member, which is really exciting. And we also have, sadly, a member who is leaving, Mary Kuzel. Thank you for your email, but we're really sad to see you leave and very happy for your next adventure though, too. I don't know if you want to say anything about your new adventures. Hi. Hi, Mary.
So I've really enjoyed my time with this committee and have just deep respect for the work that you do. So thank you again for all that you do for the citizens of the state. It's much appreciated.
Thank you so much for being here and for your time that you've given for this committee. So happy in your next adventures, but we'll miss you on this committee. So thanks again for everything. And so this will be your last meeting, is that correct? Okay. So we now will have two roles to fill in the MAC going forward. And so we'll talk a little bit about that later on in the agenda, but just wanted to give everybody an update on the current member updates. And we have now two positions to fill, one in the quote unquote consumer role, and then Mary's role, Mary is in the pharmacy role. Thanks, everybody. We'll talk more about that, but first let's approve the December 2021 minutes so we can move on with the agenda. Hope everybody's had a time to look them over, and if a member wants to make a motion to approve them, now is the moment.
Jesse, this is Jennifer. I move to approve the minutes.
Awesome. Thank you, Jennifer. Anybody want to second that motion?
This is Bill. I'll second it.
Great. Thanks, Bill. Okay, the minutes are approved. Onward. So the next item, and these two items may not take the full 20 minutes, but this is first we wanted to give a little time to review the purpose and role of the MAC, and this is actually something we do annually to talk about what the purpose of the Medicaid Advisory Committee is. So I will just drop the bylaws in the chat for everybody to see too. But on them, you can see that the purpose of the MAC, let me just pull that up so you can all see it. Or I guess, Sharon, do you want to pull that up?
Yes, I can. Give me just a
yeah.
moment.
Thank you for doing that. So while Sharon's doing that, I just wanted to review the purpose, which is in Article 4 for everybody listening in, but also and for the committee as we think about some of the new seats open, which are 2 seats. We updated the bylaws a year now, and had a really great discussion about the purpose of this committee. And just to review, so I'll just go ahead and read this quickly. The purpose of this committee is to formulate and recommend policies, analyze programs, and review services provided recipients under the Medicaid program, to improve and oversee the quality and quantity of the services provided under Medicaid, to provide a two-way channel of communication among the individuals, organizations, and institutions in the state that with the division provide and or pay for medical care and services, to facilitate the democratic process, create public understanding, and ensure that state services meet the needs of people served at a reasonable cost to the taxpayer, to plan for future medical assistance programs, or discontinuance of existing programs when appropriate. So that's really, we have a tall order ahead of us, committee, and we play many, serve many purposes to the department, and hopefully are also a role, space for the department to come to seek input and insights as well. And so really value all of the time that you all give, and recognize that it is a time commitment every month to show up. And so just want to appreciate you all for being here and the time that you give, and hope that it's meaningful for everybody, that you are able to get something out of this, and that we also are able to inform the department in the roles that we have that we have undertaken. So that is the MAC committee. We're made up of a mixture of, for lack of a better word, we do continue to use the word consumer. Personally, don't love that word, and we had some conversation about that, but we landed with it for now. I think in future iterations we'll update that. But we have a mixture in this body of providers and consumers. And when we updated the bylaws, we took out some of the more prescriptive language around the beneficiaries or enrollees who were in the MAC, and just left it more open because we recognized that we didn't want to be constrained, and we wanted to make sure that that we had a wide representation. But we did specify that in this beneficiary or consumer role, thanks Sharon for having that up, not only is this role more than half, 51% of the committee, but also preference is for people who have direct experience with the program, either through being a parent, a caretaker, or being enrolled in Medicaid themselves. And so while we do then have sort of next steps, being somebody in a nonprofit or a social service organization, we kind of tiered it out after that, but really the primary is a participant or enrollee in the Medicaid service, or the parent caretaker relatives from different Medicaid eligibility groups. And this is really because there's tremendous importance in having people speak and share about the program and talk about really how it's impacting them on a day-to-day, daily. And that's really what we hope that this committee will be, a space for people to share those experiences, to lift up what's working, and to also call out what's not. But I think the one, the caveat with that is that it comes with some real challenges. When we ask people who are directly involved in the Medicaid program to speak out and to participate in this committee, we also need to recognize that that can be a real challenge too. And so this is something that I think the committee has wrestled with for a long time, but I think it's, as we're reviewing the sort of purpose of this committee, it's important to not lose sight of this, that when we ask for consumers or beneficiaries or enrollees to participate and give their time to this committee, there's a range of challenges that they face that are different from those of us in the provider or nonprofit sector. There's stigma associated with sharing your story and even being enrolled in Medicaid in many areas. There is the challenges of speaking up, and there's also, you're getting a service, and it can be really hard to say, and these are what the issues and the problems that I'm experiencing are. We have a lot of, kind of goes back to just not even just stigma, but I think there's a lot of, can be really hard to share your story on a regular basis, what's good and bad. But I think we need to recognize the toll that it can take on people, and to be that sole voice that's constantly, or, to be the voices of people that are sharing this. And so if we want to have meaningful engagement, then we need to also recognize that inviting and prioritizing consumer voice, we also are, we need to really reflect on what that means for this committee. On the provider side, I think, providers are here to talk about their experiences, to share what's working for them and not working, so that they can provide better care for the people that they are working on behalf. But the reality is providers are also benefiting from Medicaid. It is a source of revenue for many. Not all of the providers in this, but many are, making money from Medicaid populations. Let's be frank. They are deeply entangled in the Medicaid program to, for their livelihood. And so there's a tension, right, between people being able to share their experiences on the consumer side and on the provider side. Providers also might face challenges too when they are telling Medicaid what's not working, because Medicaid also pays their bills in many ways too. So there's some tensions and dynamics I just want to surface. I'm only saying these because I want to just put these at the forefront when we begin to think about who best to seek and ask to join this committee, that these are tensions that we shouldn't shy away from, that we should acknowledge, but we also might want to rethink how we approach them so that we can make sure that providers and beneficiaries both feel like they can share their voice and they can talk about what's working and what's not working, but also that there are some, there's some power dynamics, that really do affect how people, especially people that are beneficiaries of the program, are able to share and express concerns about the program. So I know that was more than I usually kind of share, but I wanted to just lay it out there because I think we need to make sure that we keep these different strands in mind to have a strong committee, to have a committee that really serves the purposes and goals of this committee. And so as we think about filling the 2 open seats, one of which is the consumer seat that Adam Cohen used to join, let's not, what we usually do, and myself included, let's just, put a call out, anybody who knows anybody, or, just a soft ask. But if we seriously want to consider having more people that are beneficiaries or enrollees in the program, let's consider what that means and how we can create a space that really does serve the purposes. So we'll be talking about this as an executive committee more, but would certainly love your input, committee members, as we go forward. And so I will pause there. Kimberly, I promise I don't usually talk this much in the chair role, but this is a unique moment to be able to just review what the purpose of the MAC is overall.
That was really helpful.
Okay, thanks.
So I'm glad you did.
Thanks. Committee members, I know many of you have been on the committee for a long time. Some of you were new. Any thoughts about that as we seek to those new members for the committee, the pharmacy and the consumer seat? Tanya?
Yeah, thanks, Jesse. I appreciate the time that you took to go through the bylaws. And, I think from the Medicaid agency's perspective, we want to express our gratitude to everybody that's currently sitting on the committee, and for Adam and Mary, who are recently either left or leaving after today. Nate and I spent a little bit of time visiting the bylaws and talking about, particularly the vacant seat for a Medicaid member or, a related person. And, as I look through the bylaws too, some of the other things that it says, and Jesse, you did a nice job of reviewing, but as I think some of the things that Nate and I were focusing on is it describes, in selecting and recruiting new members, every effort shall be made to achieve diversity in representation, including but not limited to diversity in the members' age, ethnicity, race, gender, geographic location. And when a seat is open, consideration shall be given to the current composition of the MAC to ensure different experiences, racial and ethnic backgrounds, and communities are represented. So, just being really mindful of that. I think one of the questions that Nate and I had around this is like, what is it that we can do to best get the word out that we have an open seat for member representation in order to get a diverse group of individuals to see who might be interested in serving in this important role. And with that, I guess at a minimum, we'd put a call out to everybody on the committee. If you are aware of a Medicaid member who might be interested in participating, I think on our executive call, Stephanie had a few recommendations for some potential individuals whose maybe their children are receiving Medicaid services. but we just want to ask for your help to really see if we can get some diverse applicants who may express interest. So that's the only other thing I wanted to add to your comments, Jesse. Thanks.
Thank you, Tanya. And I think it's, what you said, and then, holding, and I guess the reason I kind of went to the previous sort of long-winded comment is just that we need to, think strategically and more openly about how to ask people to join, but also recognizing just what they're walking into, which I know you are well aware of too, but just the tensions, the power dynamics of what it means to sit, especially in the beneficiary role. And so I just wanted to lift that up. And at the same time, as you said, how can we make sure that we really, do the best to seek a wide diversity of participants. Anybody else have thoughts about either of those areas, how we can, do a better job of making sure that the MAC represents people across the state from a wide variety of backgrounds, but also that the committee itself is a space where people with lived experiences are able to not, to feel like it's a place where you can speak out and you're not just filling a warm seat, but you're also, able to share and empowered to do so. I was going to ask you, Jennifer, actually. I was going to put you on the spot with your experiences. Ouch. Yeah, go ahead.
I think, as much as I hate virtual meetings, I think that definitely makes it a lot more doable. I know, for example, UNHS, that's a long drive from there, no matter how you try to do it, and having people attend virtually, while it's not optimal, it does give that opportunity for more geographic representation.
Jennifer, is there anything you want to share just based on your experiences with FQHCs in terms of how to make sure that you feel like you're creating a space where people can contribute and, from especially people that are maybe have lived experience or attend community health centers?
As members of the MAC?
Well, yeah, or just what you've experienced from the CHC or the FQHC boards.
I think one of the hurdles right now is that we always meet during the day, and I know a lot of the patients at the FQHCs, they're at work. So I think for me as an example, I work for the association. This is part of my job. For a patient who has a job, that's time off of work and time that their employer may not, want them to take. So I think I don't have a good answer for it, but I think that is a hurdle, getting people with lived experiences to be on the MAC. It just is. Again, it works for all of us. These are our work hours. This is part of our responsibility. But to say to people, well, you need to take some time off or get a couple hours in the afternoon, it's easier said than done.
I have a question. This is Luis Rios with UHPP. So, when trying to find someone like a Medicaid, member that would be part of the MAC, we deal with a lot of clients, so I wouldn't mind asking around our team, figuring out. I just want to know how would we approach that, right? Would I use this bylaws? Maybe just kind of share some of the purpose of the committee, and then what is there do you have some sort of document that has some sort of more expectations, that way they would feel more comfortable making a decision? That'd be great.
Luis, that's such a help. I don't know if we have a little overview. I haven't seen one. If we do, so that's a really helpful thing to so we can certainly work on that. And sorry, Stephanie, I see you have your hand raised. I do just want to point out that While minimal, Jennifer, you mentioned the time constraints are real, but I do believe in the bylaws we have compensation is available for some committee members. I have to look. Thanks, thanks, Sharon, for pulling that up. But that is, it's not huge, but it is a small piece of something that's in the bylaws too that we can also include. And while we're pulling that up, Stephanie, do you want to go ahead and then I'll put that in the chat what that is?
Yeah, I just wanted to, I agree with Jennifer's point that about like when I've talked to some of my peers about like, them, whether they would ever be interested in sitting on the MAC like that, their work hours has come up, but also to Louisa's point, I think that's also a really, I've ended up having to just make things up myself because it's hard to find something that is an accessible way to explain what the MAC does. But something that I had shared with Tanya and the others, the executive committee, but I'll share with the rest of you too, is that one of the approaches that I've had, because it's kind of how I was also approached, by I think somebody who used to be on the MAC before me, but it was, I was really, I was like showing up to anything and just asking anyone who would listen to me, like, what am I doing wrong that I'm not getting on Medicaid when I should be able to? Like, I am told that I qualify and I can't get through, and like I'm having all these barriers, and who do I talk to? And someone, they told me that I should start attending the MAC meetings, and they said, that would be a way for you to understand like some of what's going on, and try to advocate for yourself during public comments, or and then eventually when there was a seat available, I think, there was one or two people who had just kind of seen it as like a way to help me better advocate for Medicaid members, because they knew that I was passionate about advocating for the experience. So I guess for those of you that do interact with individuals who are on Medicaid or family members of those on Medicaid, is just, if you notice that there are members who are like, they're trying to solve their own problems, right? And like they're trying to get through the system, or they're trying to have something work for them, or they're trying to make a policy better or make a system better, or but like, telling those types of people about this opportunity, so that all of that time and interest that they're spending on, and then the frustration, honestly, so it can be channeled because before the MAC, like I know some of you all know each other professionally and you sit in meetings together, right? But like for me, I never did. So that was my ability to understand like the differences between what DOH does versus DWS versus like the plans, and like what value-based care means, and just so many things that I did not understand because it's not my job. And I do think that like providing it and as an option for someone that wants to be able to better advocate for themselves and their peers, knowing that we're not all the same and we have different opinions, but just being able to be that voice is, it's a way to try to channel some of the frustration and also the optimism, right? Of like, so much of it for me is like, I believe that we can make things better. And that's the only reason I keep showing up to things. And so it's finding people who have some of that and just try to see if it can be an opportunity to connect them into a space where their voice can be heard and benefit, the program and those who are receiving the program, I guess. So yeah, I guess providers or plans, or just if there's Medicaid members that you are dealing with that do just seem like they have things they want to express and things they want to make better about the program, like those are people who really should, be given the space and the opportunity to try to take some of that like energy and channel it, I guess is how I see it.
Thank you, Steph. And yeah, Louise, I think just putting together that one, like a quick overview, I think could be really helpful to just even wrap our heads around, like, really what are we asking here, and what. So I think it could be something that we can work on, and would love to keep working on that. If you'd be open to like looking at something, I could start something, and I'd love to get your thoughts about it. Because I agree with what you said, and I agree, Stephanie, with what you said too. So, and Rebecca, I do just want to say in the chat, I saw you asked about where the most of the members come from. I think right now we are pretty heavy along the Wasatch Front, but don't have every, but that could certainly, we could get back to you about that too, but that's just off the top of my head. Yeah, I think in terms of next steps, I know we have another agenda item to talk about just how we're doing in the pandemic as committee members. I think we can table that for the next meeting or March, because I think but the idea is really that we want to make sure that we are just creating time and space for you all to share your expertise. And to Stephanie's point, to share the good and the bad. And I think that's like really basic, but it's just important to remind ourselves that when we're talking about a program as important as Medicaid, we need to be comfortable with hearing stories that are not working and that are hard and that might make us uncomfortable, which I know we all understand, but I think it's worth just mentioning that this committee is a space for that. And if we can't let people, especially people that are on Medicaid, that we ask to join this committee, which is super wonky, to express some frustration and some joy, I think we need to be comfortable with that range so that we can make the program stronger. So we will work on putting together an overview document of what, for something like Louise that you mentioned, I think that would be a really good first step, and bring it back to this committee, or just send it out to you all virtually online. And yeah, and appreciate this discussion, and thank you all for thinking about it. And please reach out to me if there's any other thoughts or ideas you have before the next meeting. So with that, let's move to a more wonky subject. Let's talk about the 1115 waiver post-award form. Unless there's, sorry, Laura, I should have paused. Did anybody have anything else they wanted to say? Any other members? Okay, great. Just wanted to make sure. All right, Laura, take it away. Thank you.
Okay, thank you, Jesse. So this may be familiar to many, but to quickly give context, this is the annual 1115 waiver post-award forum. And every year, this forum allows the public with the opportunity to provide comment on the progress of the 1115 waiver demonstration. You should all have the document that's being presented. And I will go ahead and read through this description of the demonstration populations before opening it up for public comment. As is standard, we will allow public comment after I read through the document and through the remainder of the meeting as well. So Utah's 1115 Primary Care Network, or PCN waiver, is a statewide waiver that gives the Utah Department of Health federal authorization to administer specific medical programs and benefits that are not otherwise allowable under federal rules. The 1115 waiver was originally approved in February of 2002 and implemented July 1st of 2002. Generally, Section 1115 waivers are approved for an initial 5-year period and can be extended in additional 3 to 5-year increments. The current waiver is approved for a 5-year period through June 30th of this year. On June 30th of 2021, Utah submitted a waiver renewal request that is pending a decision from CMS, and if approved, the waiver will continue through June 30th of 2027. So in terms of the demonstration populations, the waiver programs and benefits include, first is listed as PCN, the PCN program, which did provide a limited package of preventative primary care benefits to adults aged 19 through 64. This program was suspended on March 31st of 2019 with the implementation of adult expansion beginning April 1st of 2019. Next is current eligibles or non-traditional benefits. This provides a slightly reduced benefit package for adults receiving parent, caretaker, relative, or PCR Medicaid. Next is adult expansion. This provides Medicaid benefits to adults age 19 through 64 who have a household income up to 133% of the federal poverty level. Next is employer-sponsored insurance. Individuals in the adult expansion group are required to enroll in employer-sponsored insurance, or ESI, if it is available to the eligible individual. Targeted adult Medicaid. This provides state plan Medicaid benefits to a targeted group of adults without dependent children. Targeted adult dental benefits. This provides state plan dental benefits for targeted adult Medicaid eligible individuals who are receiving substance abuse disorder treatment. Utah's Premium Partnership for Health Insurance, or UP. This provides premium assistance to help pay the individual's or family's share of monthly premium costs of employer-sponsored insurance, or COBRA. Dental benefits for individuals who are blind or disabled. This provides state plan dental benefits to individuals age 18 and older who are blind or have disabilities. Aged dental. This provides state plan dental benefits to Medicaid and eligible individuals age 65 and older. Substance abuse disorder, or SUD, residential treatment. This provides coverage of SUD residential treatment in an institution for mental disease, an IMD, for all Medicaid eligible individuals. Utah Medicaid Integrated Care, or Umic. This allows the state to operate an integrated managed care pilot combining physical health and behavioral health services in 5 Utah counties for the adult expansion population. Does not include the targeted adult population. Intensive Stabilization Services, or ISS. This allows the state to provide intensive stabilization services to Medicaid eligible children and youth under age 21 who are in state custody or at risk of state custody and experiencing significant emotional and/or behavioral challenges. Residential and inpatient treatment for individuals with serious mental illness, or SMI. This provides expenditure authority for services furnished to eligible individuals ages 21 through 64 who receive treatment for an SMI and who are short-term residents in facilities that meet the definition of an IMD. And last is former foster care youth from another state. This provides state plan and Medicaid benefits to former foster care youth from another state up to age 26. And then below is this table that provides current enrollment numbers for the demonstration populations. And just to note, this is data as of January 3rd of this year, although the table does indicate December. And I will now open it up for public comment.
And Laura, just so I'm clear, we have not heard back from CMS about the renewal, right?
Correct.
Okay. So any of the changes that we'd advocated for or had gone and kind of contributed to in public comment, those have not been decided yet, right?
Correct.
Okay. Right. All right. Well, Laura, actually, just one other question. Do you know if there's ever any, I was just thinking about our previous conversation. Is there a glossary? I'm not suggesting we do this, but I wondered if there's ever any a glossary that another state might have put together of Medicaid acronyms or things like that. If anybody is aware of one, I was just thinking that could be something helpful to have. I would certainly appreciate that too. So if anybody is aware of a Medicaid acronym or Medicaid glossary handbook, or that would be really great. Yes, Tanya.
I don't know if we have an all-inclusive Medicaid glossary, but I know that we do have some internal things that we, like employees, use to help with acronyms, and we certainly could share that with the MAC.
That'd be great. Thanks. All right, terrific. Thanks so much, Laura.
Thank you.
Hey, next on the agenda is Brian Roach, who's going to share the update of the vaccine report.
Hello, everyone. Brian Roach with Utah Medicaid. I am bringing up my screen right now. Great, thanks. So this is a refresh of a similar report that was done in August of 2021. At the time, we said, let's revisit the rates in a few months. So this is the revisit of COVID-19 vaccination rates. A few things have changed. In that time, vaccinations are now authorized for individuals age 5 and up. So these rates now reflect members that are age 5 and up. Additionally, I changed rates in comparison, whereas previously I was just comparing members who had received at least one vaccine. Now I am comparing the full vaccination rate. So for the Johnson & Johnson vaccine, that is still just one vaccine, qualifies an individual as fully vaccinated. And for the 2 mRNA vaccines, they would require 2 doses to be counted as fully vaccinated. For anyone that is interested, they can link back to that August report using the link in this report. Again, I would encourage anyone to view our coronavirus dashboard. There is a lot of helpful information, and you can dig into the data a little bit more. It's a very helpful resource. In particular, I am focusing on Utah small areas. More information is in this link, but there are 99 small areas. Most of them range from about 30,000 to 50,000 population and have similar population dynamics. They're usually the same, similar zip codes, similar authorities, similar area deprivation index, similar population grouped into each of those 99 small areas. And below, when I scroll down there, I do use prefixes which correspond to these local health departments. So please refer back to that as needed. For sake of time, I won't review every rate in this document. It is available to each of you to review. I will just point out that it is somewhat difficult to draw sweeping conclusions from this. Some hypotheses can get disproven just by certain rates. So as an example, if we were to look just solely at high health improvement index is a measure of those with very high social determinants of health disparities, and one of the highest in the state is San Juan, and that is actually one of our highest vaccination rates within Medicaid, individuals age 5 and above, and the lowest difference with the statewide rate. So that is less disparity there. Some of the highest socioeconomic areas like Park City have the highest disparity between the statewide rate and Medicaid individuals age 5 and above. So you may draw conclusions as you look through this, but there are some areas that don't quite fit the trend. Scrolling down, I will next show the comparison between age groups. The largest disparity between Medicaid and the statewide rate is among those in their 30s and those in their 40s. That is a gap around 22 or 23 percentage points. At the extremes of the age ranges, those age 80 and above, and the 5 to 11-year-olds, it's narrower, but there is still a gap. Comparing individuals by race and ethnicity, I do want to throw out caveats that an individual may identify differently to us in their enrollment compared to what they identify to a vaccine provider and gets into the immunization database. So I would just use caution when comparing these, but I am presenting them for individuals comparison. And then finally, showing our Medicaid vaccination rates by our larger age groups. This is an important, it's an important caveat. I think what has come up before in our August meeting is trying to dig deeper at vaccination rates, comparing fee-for-service and our ACOs. And I think this paints a picture of why that is problematic. One of our highest vaccination rates is among nursing home recipients, and they are carved out of ACOs. So that does present that does raise the fee-for-service vaccination rate, but that is just it's not a random selection. So there is not an easy comparison that could be made among fee-for-service versus ACOs. But near the lower end are pregnant women. These, I think nationwide, most of us have been aware that CDC has tried to emphasize more and more outreach towards pregnant women to get them immunized. They are high risk, but have been shown to have lower vaccination rates, and we do see that within Medicaid. And also CHIP and child, so child being Medicaid children, age 5 through 18, CHIP is age 5 through 18 here as well, are at the lowest end of our vaccination rates. So I will pause and take any questions from the group.
Brian, just two clarifying questions. These are one dose or fully dosed? I'm sorry, you said that.
No problem. These are fully vaccinated rates.
I have a question. So with the, can you scroll up to the race and ethnicity breakdown?
Yes.
So, okay, so American Indian, Alaska. So that gap, I'm just thinking about how Navajo Nation is the highest vaccinated area in the country. I mean, I realize there's other tribal communities in Utah as well, but have you all dug into that or talked to the Office of Health Disparities or the tribal leaders about? I'm just wondering if there's anything that you all have learned about that particular gap.
I think so. Only a little bit. I know. I don't know if by chance Melissa Zito is on the line. Sometimes she does attend. It doesn't look like it. Previously, she has mentioned that urban Indian populations have lagged American Indians that are on reservations. So that could be part of the explanation for that, but I'd be happy to dig in more and ask the Office of Health Disparities.
Yeah, that would be interesting. I was wondering if it was, if it was on the reservations, they're doing a really great job with vaccination, but in the urban areas, if that's where some of that gap comes from. Because to your point of San Juan County being an area where there's greater risk from like the health improvement index. There's been, I mean, it's interesting to actually look at the outliers, because then it shows usually within like what is working. And it does seem like there's been a lot of work within like Navajo Nation to get vaccinations so high. And so just trying to think about, are there things we can learn from the outliers to try to then like, you know, connect some of those learnings across other populations where the disparity continues to just be really high. So I would just be interested if yes, if you in the Office of Health Disparities did have any kind of, if you all do have a conversation, I would just be curious about what you all might find or discuss, or with Melissa Zito, if there's learnings that we can, I guess, apply to other communities and populations, because it does seem like they've done such a great job in San Juan County. So just would be interested in seeing how we can learn from them and try to help get vaccinations higher in other communities as well.
Yeah, agreed. I will reach out to Office of Health Disparities and Melissa Zito.
And thank you, Brian, for doing this. I really do appreciate it. And I know that I've probably been a bit of a pain to everybody about this for the last year and a half or so. But, you know, when I looked at the breakdown of the final page, and I was looking at like the expansion population, and I'm just like going to get emotional, but just thinking how hard we worked, right, to get everybody covered. And I just think it's so important that we continue to do what needs to be done to get as much opportunity for healthy outcomes to people as possible. And I think there's so many factors, and I'm not blaming one entity or group or person, but I do think there are systemic and social determinants that lead to mistrust and lead to disengagement. And I think that shows up so much when it comes to vaccination rates. And I think even beyond just whether or not we, you know, because it is going to be about a person's, you know, decision, it is also about access and about their access into information that is digestible and that like is reaching them where they're at, and also, you know, access of relationships with providers that respect them and that listen to their concerns. And I've known both. Like I've known providers who really do give me that kind of provider relationship, and I've also known where that doesn't happen. And so I just think that that's such an important part of this too, because so many of us worked so hard to expand Medicaid to meet a gap. And it's tragic in many ways to think that during this surge that they are not going to have the amount of protection. I have COVID right now, and I'm just so glad that that I'm able to be a little bit more protected from some of the negative outcomes. But it's still really hard to be a person that's in poverty or has a disability or is older or doesn't have a car or it lives in a rural area. Like there's so many ways where then trying to navigate a pandemic is just really hard. So even for those who are not getting vaccinated, if there's just ways where we can try to think through what else can we get them, like can we get them other resources, get them antivirals, get them, anyways, I know that's a bigger conversation, and I know that Jesse's probably going to talk a little bit about that, but I just wanted to say that it's so important to me because I think it's a part of why we all fought so hard, because we knew that there was this gap where people were literally dying because they didn't have health care, and I just don't want people to die during all of this whenever we fought so hard to like get them the care that they deserve. So anyway, I appreciate you, Brian, for working on this and for Medicaid department to prioritize this data, and hope we can find more ways to help this population, but I'll be quiet for now.
That's Stephanie. Thank you for saying that. I think, Stacy, I saw your hand was raised. Can I just ask a really quick clarifying question? Brian, we don't we don't have low income data that we post on the COVID dashboard, right? Or SES data. So really, essentially, the data right now that we're looking at is kind of the best proxy we have for how people, but could, maybe not a proxy is the best word, but we don't have any low income data, right, on the, or income level data on the dashboard. Is that right?
Correct. Yeah.
Yeah.
I mean, I think there are some, there would be significant obstacles to get that. But yes, you're correct. There's not.
Stacy, go ahead. Thanks, Brian.
Thank you. Thank you so much for compiling this data. Thank you, Stephanie, for the points you brought up. I guess kind of an obvious question is, since the last time we heard from the state about, outreach from the Medicaid department, calling Medicaid members, things like that, has there been any, further action? I know that my team has done a ton of vaccine work, and we've really learned that even minimal outreach can go a very long way towards bringing people into the fold and getting people protected. So just wondering if there's been another round of phone calls, a letter, an email, anything from the Medicaid department to these Medicaid members.
So, Tanya, I'm not sure if we should open it up to some of the ACOs to speak to specific outreach activities.
Yeah, I think, and I know that we described the earlier on that I think what you're referring to, Stacy, is our efforts with our internal staff to do some of this work. And I don't think we have implemented kind of a second round with our internal staff. One thing I would mention, and then I agree, it's good to just turn it over to get some thoughts from the managed care folks. But as you look at this slide that I think, that everyone is looking at right now, and Brian, maybe go back up to the top. One of the other specific efforts, sorry, Brian, not all that way to the top of that one slide, that last slide, sorry.
Oh, at the age and...
Yes, all the categories. Okay. Keep going down. Like where we start with there we go. Gotcha. So one of our specific efforts, in addition to reaching out to the ACOs and managed care, is that we have been doing some outreach with the case managers of the home and community-based waiver programs. And, we've had a pretty high rate of success. And, whether it's causal that our interactions with the case managers, it's some of the, highest uptake of vaccinations are occurring with individuals who are in nursing homes, and obviously just them being in a place where it's we're able to vaccinate people in large numbers has helped with that. But our top group that in terms of vaccination uptake is one of our home and community-based waiver program population. So just pointing out that even in some small way, that outreach where we provide lists to the case management agencies about the people on their caseloads in terms of members who may not have been vaccinated, and whether that impacts these high rates or not. We hope that it has positively impacted the home and community-based waiver folks. And then, so with that, I'll maybe pass it along to some folks from the ACOs to comment as well.
And I see we have a question too. Maybe we'll let June go ahead. And I put that in the chat. Now, I did just want to remind people that, thank you, June. Anybody should feel free to pop in with questions. This is definitely meant to not just, this is a public meeting. Everybody should be able to participate. June, go ahead.
This is just a point of information. Which line on this chart is the base waiver one that we're looking at that regards to the homeless, Tanya?
Oh, so June, I guess just, and maybe Brian, if I go astray here, feel free to help me with this. But what you see on this particular slide, June, is the way that Medicaid identifies individuals who are enrolled in Medicaid is by what we call aid groups. And so there are many different populations expressed here. I think if you're asking about homeless individuals, if I heard that right, that would generally be the target adult Medicaid group.
Thank you.
Yeah, okay.
Yeah. Sorry, we use waiver in many, many different contexts, so it can get complicated, but yes.
And now thank you, June, for that question. And now I'll open it up to let ACOs or members respond to. And I guess I'll just also include not only, to address this, but also, well, yeah, actually, I'll stop there. I'll tack on my question afterwards. So go ahead, Brian. I think you might have unmuted yourself.
Yeah.
Okay.
So this goes way back. I mean, to really kind of the very beginning when the vaccines first started coming out, and we had worked with the department to do some public service reminders. We also, and I'm speaking for all the ACOs. So if there are any other ACOs out there that have anything different than what I'm going to tell you, please speak up. But we've done these. We've put it in all of our newsletters. We've actually mailed out separate postcards to our members to let them know where the vaccination clinics are. We've actually provided incentives, gift cards anywhere between $25 and $100, depending on which ACO that you're with, to go out and to get those vaccinations. All of the ACOs are participating in various healthcare or health fairs, I guess, around the cities and the states and the states. So we have those health fairs where we go out and educate as well. Let them know where the closest vaccination clinics are. We recommend that they get it through their primary care physician, but we know that that's not always the most convenient place to go. So we also let them know where some of the just the parking lot clinics are, where they can go out and stay in their car and get vaccinated.
Let me jump in. This is Sheila with Molina on the community engagement side. For Molina specifically, we also did a lot of partnerships with community-based organizations to get some COVID clinics going on in some of the schools. We combined those. Some of the organizations did things like math nights at the schools, where they did a combination COVID clinic. And then over Halloween, we did a lot of things with like trunk or treats that had a combined COVID clinic. So really just looking for opportunities where, families might be, for other types of things, and yet we could, have a COVID clinic at the same time to at least be able to open the door to a conversation.
And one last thing that I failed to mention, which was probably the most rewarding of all of the things that we did. We actually worked together with the local county health departments to volunteer our nurses and our doctors that work for Molina, and they went out at various days and weeks to actually do the vaccinations themselves for the individuals. And again, they said this was probably one of the most rewarding things that they'd been doing as a clinician. So, and I know, again, I'm speaking for Molina, but I know all of these things were happening with the other ACOs as well.
Brian, I'm also wondering about like harm reduction that the ACOs might be doing as well, recognizing, that if you see these numbers still and they are the same, what are you doing to also get ahead of the curve and support members that are at greater risk, even if they're not vaccinated.
Yeah, so that's a good point. Again, part of what ACOs do is we have care coordinators and case managers. And for those that are in case management, again, we're constantly in contact with these individuals to help coordinate visits to specialists or to get home health or durable medical equipment to them. And we, at that time, we'll ask them if they've been vaccinated, if they need to be vaccinated, and we'll guide them to that's a good point, though. I appreciate you bringing that up.
Yeah, I mean, what's your take on these numbers? I mean, you can't, this is, I guess I'm just, they haven't changed much since August. And when I look at kid numbers, obviously
So,
that's populational
yeah,
care.
I think the bottom line, and, you can get into politics, if you want, but if you haven't been vaccinated by now, there hasn't been, there's been so many opportunities to get vaccinated. And there are people that'll literally hold you by the hand and take you somewhere to get vaccinated. But if they haven't done it by now, 90% of the reason is because they don't want to get vaccinated.
Yeah, this is Sheila, also again, on the community engagement side. I'm also a registered nurse by trade, but speaking to people in the community and really trying to understand this, there is still a fair amount, people have their reasons for why they haven't gotten vaccinated. And what we're seeing is it's not so much an issue of access, it's several things. There are some people that are anxious or fearful about the vaccine itself. What are the long-term effects? Don't feel like it's been studied enough. There's other people that just purely feel, are uncomfortable with, mandate and, and kind of their choice. And so it's really across the board. There's a lot of factors that are playing into this. And so what we're trying to do on the Molina side, even through care management, is just like you mentioned, Jesse, the harm reduction. You're not going to sway someone's opinion if they're set on it that they're not going to get vaccinated. You're probably not going to change that opinion, but through things like motivational interviewing, helping to understand what are the barriers and, respecting where people are coming from, then we can at the very least help them to reduce those risks to themselves. If they're absolutely not going to get vaccinated, then maybe we have the ability to talk to them about, a KN95 mask, protecting themselves, protecting others, hand washing, keeping 6 feet apart, looking at some of their social behaviors, which could put them at greater risk for either spreading or getting getting COVID. So, just really trying to address it from that place for those that have just kind of locked their feet in the cement that they're not going to do it.
And the interesting thing about it too is for all of those people that haven't ever received a single vaccination, there's that group of people, but there are also a large group of people that have received their first and second vaccinations, but it's time for the booster, and they don't want to do it because they've seen bad outcomes with boosters with family members or friends or neighbors or something like that.
Thanks for sharing. Jessie just lost internet. She texted me and asked me to let everyone know she's on her way back into the meeting. It's different, I think, using her phone. But June, I see your hand is raised.
I just had a question about, and Sheila would probably be the one with the most information. What fraction of people do you think have the barrier that they can't take time off work? They lose half a day of work or salaries?
I have not personally heard that. I've not had anybody report that to me as being an issue. I do think that as a state, we've done a really good job at making the vaccines available during, off hours type schedules. I know that a lot of the COVID clinic events that we've gone out to have been after work on the weekends. I mean, there just really is so many opportunities. Most of the pharmacies are doing walk-in. I know when I got my booster, I was able to walk straight into Walmart and have an appointment. It was after work hours. So I do think that the availability in the state is very good, and that's likely not as big of a barrier as some of the other factors might be.
Just wondering if we did like clinics at some of the big meatpacking plants and the Amazon warehouses.
Yeah, the majority of employment, the companies around the state will offer paid time off to get to go out and get a vaccination. Now, it's not like an all-day thing. It'd be just a couple of hours, but
those benefits, to be fair though, those benefits are least likely going to impact Medicaid members. Medicaid members are least likely to get paid time off. They're least likely to have all of these, like they're just the least likely to have these experiences that might be true for a lot of you, but that is not what it is like for the majority of Medicaid members, because they work at places that are the least likely to give them those kinds of work benefits. And so and I mean, again, right, that's a part of what the program is supposed to do, is to cover some of these incredibly marginalized people, because there are not benefits that are adequate enough in their workplaces to give them the benefits that they need. That's why Medicaid also exists. I mean, I do think there's just some real, I hear all of that you're saying. I'm so grateful all of you are working so hard. It is so important. I would be so curious about more data and evaluation of that data, because I will be honest, I have heard very opposite things of my peers and of people that I know that live in poverty and of people that I know that are on Medicaid. They have felt like they are not getting any outreach from their plans. And I am being honest. I hear all that you all are saying, but I hear a lot of the opposite. So I'm just sharing this with you because I hope that you can take information like this as
if you can give us
feedback.
specifics. Yeah, if you can give us specifics, I'm happy to talk with all of the ACOs and
the specifics are that I've heard that, yeah, I mean, there are, and maybe it is also like a bigger conversation, but the specifics that I've heard is that there's not been any outreach related to COVID from multiple, like a number of Medicaid members that I've talked to. They've actually called the plans themselves, called the doctor's offices themselves. They've been incredibly unimpressed with like the experience that they've had. And I've been outreached about the flu shot. I never got outreach about anything else related to COVID. So I do think, again, like if you all wanted to present like actual data of like, this is the number of like health fairs that we've done. And at the health fairs we had, you know, like, I mean, I guess it's like if you all had more data so that it could be like, what exactly, because I hear the things of like, we're doing this, but some of the specifics I think would make it a little bit easier to think like, okay, what there's like maybe others could help show maybe some gaps. Like, okay, that's really good for addressing maybe 3 of the objectives of like what we're trying to accomplish. But as far as like, you know, like what populations might not be addressed with like the plans that you've been doing, I don't know. I just feel like it's not, there's got to be a disconnect, because I mean, sorry, Stacy, your hand's raised. I'm sorry. Go ahead.
Yeah, and Stacy, I see you, and somebody else, Eric, I see you too. And I think we're just going to continue this conversation for a couple more minutes because it's really important that I think we have it and think about next steps. So I just want to acknowledge that we're a little behind schedule, but would like us to continue with this conversation for a little bit longer, just because it is so critical, especially right now. Stacy, go ahead. And then Joni, and then
Thank you. I will be quick, I promise. Just want to really reiterate, you know, our experience on the quote unquote front lines with this has been very, very effective, and even minimal outreach can have a huge difference. And so we just really encourage folks not to give up and not to fall into the mindset of, oh, all the unvaccinated people that are left are anti-vaxxers. We're not going to reach them, because we are still really hearing about access barriers from people. We are still hearing paid time off, transportation, those things are still barriers. Worry about ID, worry about cost, all of these things are still real on the ground. And just brief conversations with our team have been able to really ease fears of people, been able to connect them to resources, and we've been able to change minds in pretty brief interactions. And so just please don't give up. We really have an opportunity still to reach people.
Yeah, I don't think the ACOs will ever give up in terms of trying to reach those that haven't been vaccinated or haven't received their boosters. It's something that we're gonna continue to do till the pandemic is over.
Joni, did you have your hand raised?
But let me just say real quick though, if the ACO has a coalition, and we are more than willing to look at additional ideas. If any of you from the committee have any additional ideas on how we could do a better job at reaching these people, we're all ears. We want to work together as a community to make sure we have the safest and healthiest community that we can.
Well, Brian, that makes on that, suggestion. Given that this is so critical, and I am also really concerned too, right? That these numbers, those kid numbers are really alarming. I'm wondering if the ACOs and anyone else on this call would be open to a follow-up discussion about this, so we can dig into what is working and what is not, and what we can do to further this, to make sure that we're not, to Stacy's words, to giving up on a population that is so important in our state. So I'm just wondering if you would be open to that follow-up discussion or a community conversation about this, so we can have some additional follow-up this space. I know we have limited time now, but clearly there are some things that we all could continue to talk about to make sure that we're reaching everybody.
I don't know if you're interested, but Molina is in 17 states throughout the country, and we have vaccination rates in every state. And if you wanted to see a comparison of a handful of states around the country and what those populations look like in terms of age breakdown and the percentage of vaccinated people, we can provide that.
Okay.
Just to see where Utah fits with a handful of other states in the country.
Sure. Yeah. I think that would be helpful. And then in terms of scheduling a follow-up conversation with that, would you be open to that as well, Brian? I know everybody on this call is really busy, but I also think this is such a critical issue, and we've been able to have some space in the MAC for this, but I think it's an area where there's clearly more conversation and more solutions that we can find together.
Again, we have an ACO coalition meeting once a month, and it would probably be a great topic to discuss while we have all of the 4 ACOs there.
Yeah, I think, okay. I'll follow up with you about whether or not that's a time that could work. I'm thinking also we can include some partners from like the Office of Health Disparities too, that have done a lot of investigation into this issue. So I think that could be, and other community partners. So
yeah, and I just invite anyone that is vocal about it, that has an opinion, that has information, to be a part of it.
Do you want to send me an email with the information? Because otherwise I don't know how I would know how to attend. I will do anything, as I've been offering since the summer of 2020 to get this done. So I will wait for your email.
We'll work that through, Jesse.
Okay. I will get that started and start with and if anybody else is interested in that meeting, please put your name in the chat too. And I'm sorry, Sheila, I think you had your hand raised, and if somebody else did, sometimes I see a hand and then it disappears. So I apologize for calling you.
Yeah, I just want to echo and say, first of all, I totally appreciate where Stephanie is coming from. She's absolutely correct. And I think, some of the issue here with reaching Medicaid members, historically for us, it has been very challenging. We have a pretty high unable to contact rate amongst our Medicaid population because phone numbers change often, addresses change often, and we don't get those updated, or the member doesn't update them as regularly. So that is definitely a barrier with this population. I also would echo, what Stacy said about not giving up, because, we do have a lot of work to do. But I think the best thing that I can say, and trust me, I have members in my own family that, I try to impart knowledge, and share with them what I know and how important it is that have still not, unfortunately been vaccinated. But I think it's really, how do you talk with somebody about this, very important topic? And again, I think it's really about the communication, motivational interviewing first, starting with, asking that person to share, what their beliefs are about it, and really starting from that place. Because I know that the family members that I have that have not, who are at high risk, by the way, and have been in the hospital and have been asked about this, they feel like they're being told something. And I think if the approach were different, if it was, tell me what you know about the vaccination, and respecting that people are subject matter experts of their own lives, meet them where they are. And then you can open a conversation to hopefully changing, their point of view, or helping them come to a good place with that. So how we communicate, I think, is just as critical as how much we communicate.
And one last thing, and I know that Jeff and Marissa are going to talk about the public health emergency and hopefully redeterminations, but that in and of itself right there is one of the main reasons why we're pleading and calling these members to get their redeterminations done, because as they do that, and they have moved and they have changed phone numbers, updating those in the system, and then having them give that information to the health plans, it makes our life so much easier to be able to contact these people and help them out with it.
Thank you, Brian, for that. Thanks. And I think Christine Jones, did you have your hand raised? I want to make sure you were able to talk to you. I apologize if I missed calling on you before.
I did have it raised. I was just going to reiterate kind of what Brian was saying, that as the ACOs, we're kind of feeling like we're not getting the response that we really anticipated. We've, sent out these cards and explained that they can receive incentives and receive a gift card. So we've also, at least from Health Choice Utah, we've been a little bit disappointed in the response rate, and our care managers are also heavily involved in trying, when speaking with with our members and explaining that we offer transportation benefit, and we can help these people to get to somewhere to get the vaccine. We have it on our website, we do social media, so we're really trying to communicate and educate our members. But the response rate is much lower than we thought. And then also, as someone had mentioned, that a lot of these cards that we're sending out and mailers and reminders, probably the majority of them come back because we have the address has changed. So I just wanted to reiterate that we're all trying, and if somebody can give us some better ideas in how to do our outreach, we're certainly open to that.
Okay. No, thank you, Christine. That's really helpful. And I think that is where this follow-up meeting, and Brian, I got the names that are in the chat. If anybody else is interested, I think I will follow up with you and everybody else about finding the joining the ACO coalition meeting, or in a separate meeting if that doesn't work, to dig into this, because Christine, I think what you raised is exactly what it would be really helpful to have further conversations about, and everything that we've been talking about today.
And in thinking about it, we should do a separate meeting. We should hold a separate meeting because the individuals that attend that meeting are typically the chief executive officers, and they may not be in the weeds, in terms of what we're doing exactly with vaccinations, but we ought to have our subject matter experts there. So let's create a meeting, and I'll take that action item.
Brian, thank you. And by all means, though, I think sharing this information with the ACO Coalition and the executives is also something that if they haven't already seen it, I hope they do see this report. Brian.
Oh, absolutely.
Yeah, I think
yeah.
This is, it's concerning to also think that maybe they haven't seen that, and we don't.
Oh no, they see it. It's on our agenda, every single agenda.
Okay.
Yeah.
Okay. Well, more to come. I think I've got all the emails, and thank you, Brian Roach, and Brian Munson. Thank you, Brian Roach, for putting this together, and Stephanie for all of your work on this. And just to recap, this is incredibly important, and we know that there's more that we can be doing, and let's not give up. Let's keep making sure that we are reaching people to make sure that we're keeping people safe and healthy to the extent to every way we can. So with that, I'm looking at the agenda. And Eric, I'm only laughing because I know we pushed you aside last time, and we're doing it again. And so how long is your presentation?
So Jesse, I have an alternate solution. So
yeah.
I've written it up. I originally wrote up a summary that was 5 pages long, but Tanya told me that was way too much. So I got it down to a single page, and it's just going over what the regs are in 42 CFR 438. So I'm happy just to send it out, and people can read it at their leisure if they'd like, if you prefer to do it that way.
I think that'd be great. And I'm also kicking myself because I was the one that said, let's keep this on the agenda, because I do think it is really important. Can you just tell us what you will be sharing with us?
Yeah, so it's just a quick summary breaking down 42 CFR 438 by subpart and highlighting some of the main provisions in each of those. And if that summary isn't sufficient, I can send out a more detailed one that's, like I said, 5 pages long that gets into a little more of the nitty gritty.
And what is 42 CFR C part?
They're the regulations around managed care entities.
Right. Okay. But you're going to
Jesse,
yes.
Oh, I would just offer, if we send that this time, and if we want to put this back on the agenda, maybe after the session or something, to provide opportunity for questions, I think Eric would be happy to do that.
Okay.
Certainly.
I think that would be great. Thank you, Eric, for doing that and for being here at the ready to present. But
you bet.
I also think, just in light of the conversation we had about vaccines and the role of our managed care plans in making sure that we are, protecting the health of Medicaid residents, I think it will be helpful. That's a helpful context document just to have. So, please make sure that that's something, thanks for sharing it, and we'll be taking a look at it.
You bet.
Okay. With that, I'm going to turn it over to Jeff and Maris for the enrollment and expansion update, and then Tanya, all you.
Hello, this is Jeff Nelson. It's good to be back with you. This is quite a switch of gears to be talking about vaccinations on one hand, which is what's happening on the streets right now, and then switching gears to talk about what's going to happen once the public health emergency is over and ending. I thought just very quickly, I'd let you know that included with the agenda today, you'll see the Medicaid enrollment report. That's still there. There is nothing really of note, meaning that there's a funny trend or something changing on that report. If you want to take a look at that, happy to answer any questions about that as well. And to Stephanie, I'm going to point out that there are 18,879 new adults covered in the past 6 months on Medicaid in that adult expansion you worked so hard to get past with many others on this call as well. So that was just kind of a fun moment to see almost 20,000 people have joined in the last 6 months. But with that, I'm going to jump over, if I can, to the Public Health Emergency Unwinding Plan. We do have a plan that is being circulated right now. It's a draft plan. It's about 3 pages long of what we intend to do once the PHE is over. I'm going to start with the PHE was just extended. Last Friday, we heard that it's now extended through April 16th. That means that we are likely not ending any eligibility until the end of April at the soonest. We'll again hear on April 16th whether or not the PHE will be extended yet again, or what might happen at that point. CMS to this point in time has told us that they intend to give us at least 60 days notice. And most states will tell you that's just not as much time as we'd like. We'd like to have a lot more runway to give us time to get back to even start the unwinding process. And I'm already using a term you haven't heard. When we say unwinding, we're talking about all the folks that we've kept open on Medicaid for the past now almost 2 years, in some cases, where they have not completed a renewal, or and they have not moved out of state, they have not died, they have not requested their case closed. Those are only types of cases that we're actually closing. Those have not done their renewal are kept open. Those that are over income are kept open, etc. So we know that once the public health emergency does end, we're allowed 12 months to work through all cases, and that's every case. It's the people that have worked with us, that have completed their reviews, as well as this other large group of, it's a backlog now of cases. And I corrected my numbers from the last meeting. 126,000 individuals right now are being kept open, and we don't know if they're eligible or not, or where they're eligible might be a better way to say that, whether they need to move to the exchange or move to a new program within Medicaid, or even move on to the CHIP program in some cases. And Maurice was kind enough to have some folks run some data in the background in the last meeting, in the CHIP Act meeting today, that about almost 60,000, 59,600 of those individuals are children. So that gives you an idea of the scope of that backlog of work that needs to be worked through to see if those folks truly continue being eligible for Medicaid or not. And so our approach is a fairly simple one. We are trying to think through where we can get the most bang for the buck and work through that process over the 12 months. And what I mean by that is we can focus our efforts, we think, more appropriately on those that, for example, we know some cases are over income. So we'll focus on those cases first of this backlog to try and figure out where do they belong. Is it on another Medicaid program? Is it moving to the exchange, et cetera? So as each case is pulled from this backlog, we'll do a complete renewal on the family to see where they belong. That could pull in many other, several programs, or sometimes it's just one program, depends on the family. Look at all those cases together, or programs together, and then try to get them to the right spots if there are multiple. And over time, over that 12 months, at the end of that list, we would have cases like, I'll use someone who's receiving SSI and is disabled, but has not completed their renewal. That person likely remains on Medicaid once we get to them. So those cases will be towards the tail end of the 12 months as we seek to unwind the eligibility. It's a lot of work. In talking with DWS and working with them on what this might look like, we have concerns, as they do. Their staff, and this is an interesting statistic, somewhere between 15 and 20% of their staff are new enough that they've come on since 2020 and have never ever processed a Medicaid renewal where they've had to take any kind of negative action. And that's just kind of a telling moment that they're not novices and totally brand new, but they will be learning this process on the go, on the fly, as we move forward. And again, this is once the PHE has ended, once that's determined to be over, which again could be several months from now, at a minimum 90 days from now, we think. So that's a start of that conversation, but we've put pen to paper. We do have a document that we hope to share with you soon. And really maybe this might be an appropriate meeting to go over all those items. I wanted to highlight one thing that has happened in the last, I guess it's been in the last month. It feels like maybe in the last couple of days, but probably longer. We have had a couple of meetings with the health plans and the ACOs to talk about how they can help in this process. And I was really struck that first of all, by the offer to help us, and also it's kind of a symbiotic relationship. We can help them a little bit too. As folks are moving from Medicaid and perhaps moving on to the exchange, they can help with continuity of care and work with them to select if it's Molina or Select Health, whoever, they can move on maybe to a product that's very similar so that their doctors don't change, et cetera, as they move on to the exchange. That seems to be a helpful thing for them. And from our point of view, there are many cases that for a paperwork reason never get evaluated. There was at one point I noticed in our conversation that there seemed to be a misunderstanding that anybody that gets reviewed by or doesn't get reviewed by Medicaid, if they're dropped off the Medicaid program, that we automatically send them to the exchange. And that's not true. We only send people to the exchange when we know that they are not Medicaid eligible. And that's important. That means that if we look at someone and realize that they're over income for the programs that we can offer at the state level, we can send that case to the exchange. But somebody who is in that situation that doesn't complete their renewal is not automatically sent to the exchange. They close for a paperwork issue. So we've worked with the health plans we're trying to, in the throes of right now, producing a closure list. This would be people that are leaving the program other than because they've requested their case closed, have died, or moved out of state. Obviously, those are folks that we probably don't need to contact at this point. And we're probably focusing right now mostly on the CHIP program, which does allow folks to have negative action right now. But we want to give that list in advance, divided by the health plans, divided by who they cover, and give them essentially their own people to say, here's a group of people that we have sent on to the exchange, and here's the rest of the folks that, for whatever reason, didn't complete a renewal. Again, this is likely in the CHIP program for right now. So our hope is to get that, I'm going to say February. I'm hoping that fingers are crossed for that, but as soon as possible to start giving that information so they can get used to getting that type of a list. Then once the PHE does end, we can continue giving that list so they can have kind of a second look at the case and hopefully pick up some of those cases that are falling in the cracks if that occurs. So that's some of the information that we're starting to get together. And I'm already seeing requests for more like that list, and I'm sure we can entertain some of those thoughts. Of course, with data sharing, it's always complicated, but we'll certainly work out what we can with folks. But that's just a little bit of an update of what we're trying to do. Again, we're looking at those activities we can complete now that will help people to make this an easier process. The message really is the same as it's been for the last several months. Updating addresses, as you've heard today, is an issue for us. We need to get those addresses and that contact information kept up to date. That's quite important. As well as if folks do receive a review, Utah's unique that we are continuing to do reviews right now. That's a good thing. That means they don't get caught up into that backlog of cases and cause any potential disruption later on. It means that they can renew their case today, and their case typically would run for another 12 months. So if they renew it today, we'll be talking to them next January. We hope that can occur in most cases. So again, keeping the contact information up to date so we can do that activity and the activities you just heard about with reaching out on vaccinations, et cetera, is really paramount. And we're not alone in this. As we talk to other states, same concerns are coming up almost everywhere. We're worried about the population that we don't know where they are. And keeping that information up to date has been very important. Another item I'll just quickly mention that we have done on the health department side is we've empowered the health program representatives. Those are state employees that help to select which health plan somebody wants once they become eligible for Medicaid. Those folks can now help to update addresses and keep the email and phone numbers up to date. Additionally, the state of Utah, because it was our once every 3-year time to send a notice, sent a notice out, the notice of privacy practices out in December. And in so doing, we included a little colored stuffer there that reminded people to keep their address and contact information up to date. And it's not lost on us that we're mailing something to people that they may not see. But our hope is certainly that they'll pick up this paper as they do move, because people will move this month and next month as well, and keep that close by where they can update that address and information. And it certainly caused an uptick in calls. I think we've been updating a lot of email addresses is what I understand. And I know Todd Deff's on the call. Maybe he can give a quick update on anything else he's seeing there. But those are some of the activities we've done to this point in time, and I'll just be quiet for a minute and let Merce take over anything he wants to share on what DWS is doing.
That was a rookie move and not turning off your mute button, so I do apologize for that. I think Jeff has covered a lot of the fears that we have moving forward. One thing that is very important for us, Medicaid is our largest program, but we administer other programs too that are also going to be affected by the pandemic. So as you would imagine, not only do we have the unwinding work to do, there's going to be all these other programs that DWS administers that will also want to make changes. In preparation for the PHE end, we are trying to remain staffed up. So we have hired an additional 43 staff that are currently in training. That'll help us meet the demand of the increased workload once the PHE hits. Once the PHE ends, and we are banking kind of like everybody else is this might be that last extension, although there's no guarantees for anybody, right? In addition to that, we have just concluded another open enrollment for the FFM. We received about 25,000 account transfers. without really suffering for timeliness or having any major impacts to our outcomes. Perhaps if I can digress for a second and ask the question. Usually I'm the one that gets questions asked, but I'll reverse the table and perhaps ask Brian or anybody from the for the ACOs if we have any ideas. What is the percentage of return mail that we have received on your guys' efforts to contact customers?
We were just talking about that. It's 40%.
That's a good number to have or be aware of as we embark in a similar endeavor. So
Let me clarify. This is Sheila, just so we know.
Just unable to contact.
Yeah, 40% are unable to contact. So, yeah, it's quite high.
All right, Jesse, I didn't have anything else in mind to give as far as the DWS update ongoing. If there's something specific you want me to add to this, I will be glad to do so. Just let me know what that is.
Can you just remind me, in terms, I know we've talked about, and I know I bring this up often, text updates, but I have heard other states are doing just like the occasional text message. Maybe that's something for a future conversation, but we have that capacity, right? A text message that doesn't just say, check your My Case, a text message that says, please make sure your information is correct, or something simple like that.
It's something to consider. You're right, we currently have utilized text to just tell the customer to go into their My Case for just simply because we had confidentiality concerns. That's the practice that it's been there. But what you are advocating, I actually don't think sounds unreasonable. It's something we should probably have a lengthier discussion about to potentially do something along those lines.
Okay. Great. As opposed to my many unreasonable requests, I'm glad that one fell into a better category. Great. Okay, well, that's perfect, Mars. I think if there's other things in the future, but especially, I know we're getting tight on time, but thank you for that update. And Jeff, sorry, just one follow-up question. When do you expect you said the unwinding plans are, when roughly do you think those might be publicly available? Or
I will give you the CMS answer of soon. We'll work on that as soon as we can and get that out to you. We do want to make sure we review this and that we're all in agreement that this is the plan going forward. And I will also say, I fully expect that plan to morph and change as we get better details and better information. Right now, we have to make some guesses in some areas. And as we get closer and understand better who we are keeping open and why, I think that plan will morph a little bit. But the framework, I think, could be shared soon.
Well, yeah. Thank you. That sounds, we'll work with that for now. I know you all have a lot going on as well. It's not like there's a session that's quickly underway too, or here upon us, but just feels like it's already been weeks. Okay, well, thank you so much for that. And all right, Tanya, I'll turn it over to you. I know you've got a lot to cover in a short amount of time, so feel free to take away. I think with the consolidation report too, I guess that's not.
Yeah, you know what, with the consolidation, I just put a few links in the
Tanya, I think you lost audio for me. Is that for anybody else?
Okay. Darn it. Here we go. I was just saying that in terms of the consolidation, I just put a quick link, a couple of quick links in the chat, and I won't spend too much more time on that. During the Social Services Appropriations Subcommittee meeting yesterday, Nate and Tracy gave a presentation about consolidation, and that gives a good overview for folks that are interested. And then I just put the consolidation, DHHS consolidation site for anybody who wants to get more of an update. So I'll leave it at that as far as the consolidation goes. And then just in terms of a few things to report out to the committee, one thing we wanted to share is just an update about where we're at with our long-term recruitment for an ongoing Medicaid director. Many of you may have seen that earlier in January, we issued a news release informing folks that we had originally, the governor's office had appointed an individual, Jack Sespanowski, if I'm saying his name right, to come to Utah from Texas and become our ongoing Medicaid director. And unfortunately, Jack had a change in circumstances where he had a medical emergency with a member of his family that left him in a position where he didn't feel like he could accept the appointment. So, you know, we were disappointed in that news, and we definitely send our good wishes and wish Jack the best as he goes forward. But for us, in the interim, I'm going to continue to serve as the interim director, and we're working with the governor's office to, you know, work toward making it a decision about our final, who our ongoing Medicaid director would be. And I think we'll be seeing some information on that. A decision on that should be forthcoming soon. I'll use the CMS and Jeff's soon again. So I think Jeff did mention in his report specifically that the public health emergency had been extended. So that goes through April 16th of 2022. And, you know, all the things that Jeff talked about in terms of how that impacts the unwinding of the PHE and all of that good stuff. Just a couple of legislative updates. As I mentioned, the Social Services Appropriation Subcommittee meeting started yesterday. And, you know, for folks that are interested, that are listening to this discussion, they're probably interested in the Social Services Appropriation Subcommittee meetings. And if you get on the legislative, the Utah le.utah.gov, I think is what it is, you can find the Social Services Appropriation Subcommittee meeting schedule, and there's an opportunity when those meetings are happening that you can join remotely and listen in. And, you know, we'd encourage people to do that, to just hear what's going on with Medicaid and the other social services programs that are overseen in that committee. But in terms of just a few specific things upcoming, and this is based on kind of draft agendas to this point, so it is subject to change, but this upcoming Monday, we'll have several agenda items on behavioral health services. On Tuesday, the 25th of next week, the healthcare administration, specifically the Medicaid building blocks, will be covered during that meeting. And then on the 26th of January, so Wednesday, several items about long-term services and supports will be covered. And then finally on the 27th, some additional Medicaid items will be covered too. So just a little bit of a heads up that next week is kind of a big week for Medicaid and DHHS in terms of the different topics that are going to be covered during social services meetings. And then I just thought I would mention that we have been reviewing a lot of bills, and we find that many of them don't affect the Medicaid agency directly, but there are a few that definitely do. And I thought I would just give an overview of a couple of bills, which in no way is inclusive of potentially everything that could be impacting Medicaid, but just a couple things to bring to folks' attention. So House Bill 200 is a bill from Representative Ellison, and it modifies the medically complex children's waiver statute to direct the department to enroll an additional 300 kids in addition to about the 570 or so that we currently have enrolled. So it would be enrolling 300 additional kids. And it does make another important change, and that is that it eliminates the requirement for the department to only enroll individuals during open application periods. It removes the requirement to hold open application periods and allows families to just apply for the program on an ongoing basis. And then, and I guess I'll just go through these, and if anyone's got questions, maybe we can just wait for those at the end. But Senate Bill 105 is Senator Kitchen. That's a Family Planning Services Amendment is the name of that bill. It requires the Medicaid program to apply for a waiver or state plan amendment to extend family planning services to low-income individuals who have an income equal or below 95% of the federal poverty level. Anyway, so that's one that we're watching. House Bill 167 is Representative Brammer. It's called the Mental Illness Psychotherapy Drug Task Force. And this creates mental health or mental illness psychotherapy drug task force and requires the task force to study and make recommendations on drugs that may assist in treating mental illness. And the task force right now, the way the language reads, is intended to be chaired by the DHHS executive director. I think there's some thought that it may be better to also include a designee to not make that a mandate if that bill happens to pass. Another bill is Senate Bill 41, Senator Kennedy's bill on behavioral health services amendments, and it seeks to have the department award a grant to a local mental health authority to implement or expand an integrated behavioral health program and to develop the proposal to allow the Medicaid program to reimburse a local mental health authority for behavioral health services. It directs us to apply for a waiver under the state plan or under the state plan to implement this proposal. So those are just a couple. I didn't want to go through all the list because everybody's got the ability to kind of look on the LE, the legislature's website to see what else. So those are the few that I had in mind, and maybe I'll just pause and see if anybody else has any specific bills they want to talk about or. Okay.
Tanya, oh, no, go ahead. I'll wait till the end. This isn't about.
Oh, okay. I was just going to mention in terms of the, I know we've talked about before the ARPA funds that are allowed under the Home and Community-Based Services enhanced funding, where Medicaid, Utah Medicaid has the ability to pay providers 5% supplemental payments based on their previous quarter's expenditures. And we're getting closer to a critical time period. So where we're at right now is that of all eligible providers, and just a reminder, these are home and community-based waiver providers, home health and personal care agencies, behavioral health services providers, and school-based services providers are all eligible for this 5% enhancement. And to date, since we gained CMS approval, we have about 70% of all those providers have attested and received a payment. And the payments that we've made so far are $15.2 million to providers. We'd really like to be able to get that money out to the remaining 30% of providers who have not yet attested. And March 31st of 2022 is the time period in which a provider has to attest in order to be able to get all the supplements back to April 1 of 2021. If they attest after that time, they'll only be able to access the 5% of the immediately preceding quarter. So anything that we can do to continue to get the word out to providers who we think may be eligible, it's right at the front of the Medicaid webpage. There's a ribbon across the top that says you may be eligible for a supplemental payment. Click here to see more. We just want to encourage providers to do that attestation, and you get access to these millions of dollars that are still on the table. And a couple other just updates about Medicaid, our Medicaid policies. One thing we wanted to mention is that a couple of years ago, we had submitted an 1115 amendment to be able to provide housing related services and supports to the targeted adult Medicaid members. And it's taken a lot of back and forth discussion with CMS, but we are now feeling like we're really close to a potential approval. And so we're really excited about that. We've been meeting with stakeholders over the last month or so to get some additional ideas about how to best implement this service. We couldn't take final steps or full steps without CMS approval, but what we're thinking is that now the implementation phase will begin, and we're hoping that we're going to be in a spot to implement the housing services somewhere in the fall. So perhaps like September 1st, that we'd be ready to implement those services. And then also just a reminder that we submitted the medical respite and fertility preservation 1115 waiver amendments at the end of the month last month. So we'll be waiting to have some conversations with CMS to see, what their thoughts are. It's in the period right now where it's out for public comment on the federal side. There's a 30-day public comment period for those on the federal side. And then we wanted to just let folks know about a couple things. One is that we have recently opened a code for vaccine counseling. It's specific, right now it's specific for COVID vaccine counseling for children. It's a 15-minute code, and it allows pharmacists and entities to provide vaccine counseling to Medicaid members. And it, again, it's specific to EPSDT eligible, so individuals up through 20. We also have recently opened coverage of over-the-counter COVID tests, and they're reimbursable for Medicaid members when they're billed at the pharmacy, and it has to be with a physician's prescription. And we're looking at that policy in terms of how to make it as user-friendly as we can. So we're trying to decide if there are ways that we can make that more accessible, and maybe we can report on that next month in terms of our final coverage. And then lastly, we have recently initiated coverage of 2 new oral COVID treatments. They're antiviral drugs, 2 different drugs that have recently opened. So with that, look at that. There's 3 minutes left. I will close.
Thank you, Tanya. That code for vaccine counseling is really exciting. Is it just for pharmacists, or just want to clarify?
Yeah, Jen, I think it is, but Jen, will you clarify?
Yeah, it can be given by any provider, and it can be billed separate from the visit as well. So it can be used as an add-on code. So that was something that was asked actually when CMS presented this. It's meant to kind of overcome resistance and any sort of hesitation, provide education, and allow providers in various settings, whether that's the pediatrician's office or at the pharmacy counter, to work with, eligible population and help encourage vaccination. So
I know you said it's just for kids, but is there like a dyadic component if the parent is there too, and healthy parents, healthy kids kind of thing? Could there be, could a parent be billed too if they're seeing their pediatrician? Because I got, I think I was boosted when I went to my child's visit.
Yeah, the definition of the code is specific to children. And so at this point, the code, the definition itself from a standardized, uniform, national standard is for children. So it would really only apply for the EPSA eligible population. Yeah.
Thanks. That's terrific. Tanya, one more question. If there's any other lingering questions, please throw them in the chat or speak now. Today in social services, there was a presentation about the new innovation healthcare collaborative that's underway. And the presentation started with just talking about Medicaid. And I wanted to see if the Medicaid division is part of this collaborative or will be part of those conversations.
So I'll just say, Jesse, from my point of view, at least I haven't been actively engaged in those conversations yet, but I know that there is, a significant amount of interest in making sure that we're part of those discussions. So I think that is what's intended, although I don't know that there's been a whole lot to date.
All right, okay. Thanks. Anything else? Anyone? All right. I know we have there'll be some follow-up to committee members between now and then. We're going to work on one pager to help get the word out about joining the committee that Luis had mentioned at the beginning, and we'll be following up around a conversation about vaccines and Medicaid beneficiaries. And everybody, hope you stay healthy, stay, stay as well as you all can be right now. Thank you, everybody, for being here. And we'll see you. February will be an informal legislative meeting, and Sharon will be sending out information about that, but it will be a shorter, more informal meeting just to recap what's happening about this session. Great. Thank you, everybody.
Thanks, everyone.
Thank you.
Bye-bye.
Thanks. Bye.